but it's better than paying an exorbitant amount out of pocket. I'm Dr. Meghan. I'm a board-certified physician in internal medicine, lifestyle medicine, and obesity medicine. And this is really important because I actually prescribe these medications all the time. I actually talk to patients about their weight all the time. I've helped hundreds of patients lose weight, and I'm here to help you too. I'm on 15 milligrams. First of all, what dose of naltrexone on bupropion do you start on your patients to lose more weight? I don't seem to be losing yet. I started a month ago on 50 milligrams of naltrexone and 150 of bupropion, but did not tolerate it well and had to go down. Now I'm taking 25 of naltrexone and 75 of bupropion. I seem to be tolerating this well. What dose and how long does it take for most patients to start losing on this? I still have about 6 more weeks to go on this dose before I go up. Okay, this is a great question because this person is already on Mounjaro, but they're adding an oral medication, which is Contrave, to their weight loss medication routine. And so in theory, tirzepatide and Contrave for the right person can definitely be used together. When I prescribe Contrave, so that's bupropion and naltrexone, and I've made a bunch of videos on this, so I will leave those linked below. But when I prescribe bupropion and naltrexone, which is called Contrave when they're combined, a lot of times insurance will not approve the combination pill. But the good news is that both bupropion and naltrexone are available as generics. The forms are just slightly different, so you kind of have to make your own and dose it a little differently. It's not as easy to use as Contrave in the pill, but it's better than paying an exorbitant amount out of pocket. So for me, bupropion and naltrexone, the dosing is going to differ slightly depending person to person. That's how I do it. I tailor it person to person, depending on what they're on already, what their side effects are. But in general, what I will do is start somebody on bupropion, 150 milligrams extended release, take it in the morning. You don't want to take it in the afternoon, it'll keep you up all night. And naltrexone, now generic naltrexone only comes in 50 milligram tablets. That's very annoying. And naltrexone of the two seems to be the one that gives people a little bit more trouble in terms of side effects. So I will always start people on a quarter dose of naltrexone. Again, it's annoying, you have to get a pill splitter, but a quarter dose of naltrexone, so that's 12.5 milligrams. People can take that in the morning or they can take it at night. At night might be a little bit easier in terms of tolerating side effects. And then after a week or 2 weeks, depending on how people are doing, I will bump them up to 300 milligrams extended release bupropion and half a tablet or 25 milligrams of naltrexone. From there, you can go up a little bit more on the bupropion. Generic Contrave, I believe, only goes up to 360 milligrams of bupropion, but bupropion on its own, you can go up to 450. Naltrexone, as Contrave, the maximum dose is going to be 32 milligrams a day. But again, it is approved, you can take it up to 50 milligrams per day. So a lot of it is just you're kind of fudging it a little when you are prescribing it outside as a generic. But so it does take a little bit of finagling because everybody's going to respond differently. But yes, so after 1 to 2 weeks, I will go up to 300 milligrams extended release bupropion daily, take it in the morning, and then naltrexone 25 milligrams, take it morning or night. And then from there, after at least a week or maybe 2 weeks, I might bump them up to, usually I'll keep the bupropion as it is at 300, and then the naltrexone, they could do 25 milligrams twice a day. So 25 in the morning, 25 at night, or 50 milligrams once a day. That really depends on how well the person is tolerating the naltrexone, but those are some directions that I will potentially go in. I will say I don't love Contrave in terms of all the oral medications. It's probably the one I use least because I feel like it's the least effective. It's more effective than metformin usually, But phentermine, in my experience, tends to work a lot better. Phentermine topiramate, I think, also works better, but some people just can't take that, and it certainly is worth trying for the right person if I'm looking to get their BMI a little bit lower. They've done all the lifestyle things, they're maxed out on their GLP-1 medication. It's definitely worth a try if it's the right person. I never really have too high hopes for it, but some people do really well in it, and you just never know until you try. Usually in terms of results, I like to give standard assessment time is about 12 weeks. So if somebody hasn't lost any weight on an oral medication and they've been tolerating it well and they haven't had any supply issues and they've been taking it normally, everything's fine in terms of logistically getting it and no delay with regards to side effects. At about 12 weeks, if they really haven't lost any weight on the medication, I'm usually not going to continue it. So that's a good ballpark that I use when I'm prescribing. Thank you so much for all these great questions. If you have a question after the video, you can leave it on this video or you can put it on another video. I'll find it and I will add it to the list. If you want to work with me directly, I do work with people as a life coach to help with the non-medical aspects of weight loss. I help people around the world with this, people who can't get themselves to a gym, people who have a very, they may be on a GLP-1 and they still have a very chaotic or unstructured or difficult relationship with food, people who want to try to do the best that they can to never start a GLP-1. I work with a lot of those people as well. So if you are interested in hearing more, I will leave all that info down below. Thank you so much for watching and please be well.